Good afternoon, everybody, and welcome back. I hope everybody's had an opportunity to take a break, grab a bite, to eat, and also to visit the exhibit hall in search of the answers to the rest of our scavenger hunt questions. It's now my pleasure to introduce you to Dr. Heather McKenzie. Dr. McKenzie obtained her undergraduate medical degree at McMaster University and completed her internal medicine residency and endocrinology fellowship at Dalhousie University. She now practices endocrinology and internal medicine at the Moncton Hospital. We're very pleased that she has agreed to join us today to talk to us about diabetes and driving. Over to you, Dr. McKenzie.
Hi, thanks. I'm just going to share my presentation. Okay, here. There we go. So as Erin said, we'll talk about diabetes and driving today. And if you work with me at the Moncton Hospital, you'll probably know that I'm obsessed with diabetes and driving. It's one of the things that I think is really important to talk about for both the safety of our patients and for public safety as well. So these are my disclosures. I'll give you a second to look at those. And for an outline today, I'll go through some of the evidence around the recommendations for diabetes and driving and sort of why it's actually important to review this with our patients. There are several institutions that have different recommendations around diabetes and driving, including Diabetes Canada, the Canadian Medical Association, the CCMTA, which is the Canadian Council of Motor Transit Authorities, and the New Brunswick Department of Public Safety. And spoiler alert, they are all somewhat different. And then I'll go through a summary at the end. So we all know how diabetes can affect driving, and most of our focus when we chat to people about this is on hypoglycemia, but there are a few other things that we should know about as well, including potentially hyperglycemia affecting driving. And people with diabetes can have multiple complications that can be associated with issues driving, such as neuropathy. If you can't feel the pedal, then you don't really know what is going on. Amputations, particularly lower limb, peripheral vascular disease, and visual impairment are also important to consider, as well as associated disorders, especially those of macrovascular disease like myocardial infarctions, CVAs, strokes, and obstructive sleep apnea, which can cause fatigue and actually falling asleep behind the wheel. But for most of this presentation, I will end up focusing on hypoglycemia. There's quite a bit of evidence to go through around that. So this is an older study of patients with insulin-treated diabetes and their adjusted rate ratio, for most of the studies, adjusted rate ratio of crash. So about 1.3 for a rate ratio if you take the average for people with insulin-treated diabetes versus patients or just people without diabetes. And about 0.4 to 3% of all road accidents are caused by medical conditions. And then 18% of those accidents are related to insulin-treated diabetes. So actually a pretty good proportion, about 1 in 5 of medically caused road accidents are caused by diabetes. But through a lot of these studies, it's quite difficult to assess the true accident rates, particularly because a lot of the studies were done in a time where many patients did not use CGM or flash glucose monitoring. So we didn't really know exactly, we couldn't retrospectively look back on their blood glucose and know, did it have a big fluctuation at that point. We also know that patients self-impose driving restrictions, which is very good and very responsible. But obviously affects the accident rates. And there are multiple issues with study methodology as well, such as some studies really didn't control for the number of miles driven. And accident severity is really unknown. Is it a fender bender or is it something where you've actually caused a significant accident with morbidity or mortality for someone? And so crash risk actually decreases throughout the age span in type 1 diabetes. So younger people, as is often true for people without diabetes, do get into more accidents. But overall, the crash risk is still higher than those without diabetes at all. And people with type 1 diabetes are almost 3 times more likely to report a crash than a sibling control. So it's really quite important to ask all your patients, type 1 and type 2, about this. And I really like this little cat down here freaking out because I just got in an accident. Poor little cat. So they have found through a few studies that a 1% reduction in A1C leads to about a 26% increase in relative risk for a crash. And severe hypoglycemia and hypoglycemia unawareness is actually associated with crash risk in any age group. Um, Things that are not associated in these studies are diabetes complications, their day to day glucose control, and treatment patterns like how often they give their insulin. So they have found that actually blood glucose awareness training will decrease the accident rate to about 6.8 per million miles versus 29.8 per million miles, and helps people improve their decision making as to when not to drive. So we know that people have an increased driving risk if they've had a severe low in the last 2 years, especially if their A1C is lower, as we talked about previously. If they've previously had a low while they were driving, or if they don't monitor their blood glucose before driving, if they have hypoglycemia awareness, as we know, and if they are treated with insulin more than secretagogues. But patients with type 2 diabetes who are on secretagogues and non-secretagogues, so combination therapy, do still have an increased driving risk. And they've actually found that performance deteriorates in driving at a blood glucose less than 3.8. The study for this one was really interesting because they actually induced hypoglycemia in patients with diabetes. I don't think that would be a very fun study to participate in, but they have found that cognitive recovery takes over 40 minutes. So that's the reasoning behind the waiting 40 minutes to move your car again after having an episode of hypoglycemia. And the thing that scares me most is hypoglycemia unawareness. And the statistics here are that about 4% of people with normal hypoglycemia awareness said that they would drive when they were low. If that wasn't scary enough, then 43% of people who have hypoglycemia unawareness said that they would drive when they were low. And that's like when they were actually having a low, they would prick their finger or test it with a CGM or FGM or what have you, and they would, be blinded to the number and be asked, would you actually drive? So that's kind of a scary thought. So just to talk a little bit about hypoglycemia unawareness, we all know the physiology of this is that a shifted threshold for your adrenergic symptoms is lower now, closer to your neuroglycopenic threshold. So you don't get your warning signs of your usual epinephrine responses, and your counter regulation is actually defective as well. So some of the first signs for hypoglycemia unawareness aren't the sweating and the shaking. It's more of the confusion and loss of consciousness. And your warning signs don't last very long with hypoglycemia unawareness. So this is obviously very bad for driving, because if you want to pull over, you may actually go unconscious before you do. And severe hypoglycemia, there's multiple risk factors in the Diabetes Canada guidelines for people with type 1 and type 2 diabetes. They do differ significantly. But again, severe hypoglycemia, especially recurrent severe hypoglycemia, is a risk factor for hypoglycemia unawareness. So for type 1, just going through some of these risk factors: prior severe lows, current low A1C, and actually adolescence is one of the risk factors as well. So it's really important to talk to our patients who are in transitional care from pediatric to adult care, or who are starting to drive, that, hey, listen, this is a risk. Type 2 diabetes actually people who are of an older age or who have cognitive impairment are actually at risk of hypoglycemia, as well as people with food insecurity, poor health literacy, or long duration of insulin therapy, among other things. So I have some bad news. Only about 15% of patients self-monitor their blood glucose before driving. I swear more people in my clinic do it, but I don't know, because we just rely on people to tell us. And only about 50% of drivers report following minimum driving requirements, which we'll discuss afterward. And only about half of patients with type 1 and a quarter of type 2 have reported discussing driving guidelines with their physician in the past. So it seems like we really do have work to do to prompt people to not only just talk about it, but actually monitor their blood glucose before they drive. And of patients with multiple recurrent severe lows, 68% still had their driver's license. And in New Brunswick, it's reportable. Actually, required reporting, I should say. So to review the guidelines on diabetes and driving, we'll go through these, and particularly the ones, like I said, are relevant New Brunswick-wise. There's reporting requirements by the Canadian Medical Association. Reporting is a bit of an interesting thing, because it does decrease accident frequency in diabetes patients. They did a study in Ontario prior and after a reporting period. There was actually a 41% accident risk reduction in patients with diabetes once reporting was required. I don't think it still is, but we'll see. So Diabetes Canada requires a medical exam, or I guess recommends a medical exam, at least every 2 years with complete assessment of their diabetes control and their complications. So pretty much a usual visit for us. And commercial drivers need an exam at the time of application for their commercial license. And anyone treated with insulin or secretagogues, they actually need to log their blood glucose values either with a memory meter, which makes sense, every meter will hold blood glucose values, or an electronic record or a sensor. And commercial drivers need to include at least the last 6 months, and the logs need to be verifiable on request. So they need to be able to have their meter with them or have their records. They also need to have blood glucose monitoring supplies available and within reach in the car, and have rapid acting carbohydrates available and within reach. They need to consider checking their blood glucose before and at least every 4 hours while they're driving, or wear a CGM. And many of our patients, thankfully, are blessed with insurance coverage, and they can wear a CGM or a flash glucose monitor. They recommend not to drive if blood glucose is less than 4. So it's not the same as the old 5 to drive, but don't start driving again after treating it until at least 40 minutes until you're over 5. And to actually stop driving immediately if you have a severe low when you're driving. That's not been frequent. And to notify your healthcare practitioner, whoever it is, as soon as possible, ideally less than 72 hours after a severe low while driving. I have had people who have had severe lows while driving, and when you see them at their next appointment, they're like, oh, I had a low 3 months ago while I was driving. And it was like, ooh, gotta remind you of some of the guidelines. Kind of scary stuff. And so if folks have hypoglycemia unawareness or any severe low in the last 12 months, they actually have to measure their blood glucose before driving, and at least every 2 hours while they're driving, or wear a CGM. And they must stop driving, and they have to be reported if they have any episode of a severe low while they're driving in the last 12 months. So not just a severe low at any time, or more than one severe low while they're awake but not driving in the past 6 months for private drivers, and 12 months for commercial drivers. So the reporting requirements are mandatory in New Brunswick. I know we have some Ontario folks here, so mandatory in Ontario as well, but that's from the CMA Driver's Guide in 2017. There's a few provinces that are discretionary. So when training in Nova Scotia, it was. So I'm trying to get used to the mandatory reporting requirements now. And so from the CMA, to continue, they recommend a case-by-case assessment of people's ability to drive, including their frequency of hypoglycemia, their severity, and their hypoglycemia awareness. And they need a yearly exam with screening for complications. So their neuropathy and retinopathy, I guess most relevantly. And they're able to drive if they have a reliable and good knowledge base about controlling blood sugars, and they're able to avoid severe hypoglycemia. So there's not as much sort of prescriptive recommendations as there is in the Diabetes Canada guidelines. But they do recommend if they have no complications that would affect safe driving, they can go ahead. There is a commentary in there and an update on commercial licenses in the 2017 CMA Driver's Guide. Is that folks are not able to get or maintain a commercial license if they have a severe low while they're awake or any hypoglycemia unawareness. But their license can be reinstated if they have no severe lows in the past 6 months or their hypoglycemia unawareness has resolved, which usually takes, a good 3 months of having reliably higher blood glucose and complete avoidance of hypoglycemia. Now, for these guidelines, the Canadian Council of Motor Transit Authorities says that people are eligible for a license if they have type 2 diabetes, so they're a little bit more specific, if they have a good understanding of their condition, and they follow the physician instructions about diet, sometimes medications, glucose, monitoring their blood sugars, and prevention of hypoglycemia. And they meet conditions for maintaining their license, which is basically they come to their visits, they go to their appointments for surveillance for complications, especially retinopathy, and they stop driving and treat immediately if they have a suspected episode of hypoglycemia. They wait appropriately after they've treated it before driving again, and to report to the transit authority, if they start on insulin therapy. So any insulin-treated private drivers, either type 1 or type 2, in addition to what's listed on the previous slide, they don't start to drive if your blood glucose is 4 to 5 unless they have prophylactic carbohydrates. And they recommend blood glucose is tested before driving and every 4 hours, and to have readily available glucose. So some of the same things run through all of these guidelines. Commercial driving can be a little bit more complex, as you see by this very long wordy slide, but basically they need an initial assurance to the driving authority from their physician that they're competent in blood glucose measurement and management. And they recommend that diabetes be well controlled with an A1C less than 12, and not more than 10% of values less than 4. So no extreme hyperglycemia or hypoglycemia frequently. If they've not had any significant changes in therapy, and if there are significant changes in therapy, that they monitor appropriately to make sure their glycemic control is actually stable. They need to monitor adequately, and they need to know how to treat hypoglycemia. They need to be reviewed annually. And there's a few conditions as well, like having their work schedule be incompatible with their insulin regimen. They don't start driving until their blood glucose is over 6. So this is a bit of a difference in commercial drivers in these guidelines. And they must test before and every 4 hours. And then obviously have monitoring equipment and glucose with them. Now, to comment on severe hypoglycemia in private drivers, they Must have stable glycemic control after being identified to have episodes of severe hypoglycemia and no further severe lows while awake or asleep over the past 6 months. So we really have to clear up the lows. And to maintain their license after getting it back, they need to test their blood sugars immediately before driving and every hour while they're driving if they've had severe hypoglycemia. And you don't start or continue driving unless your blood glucose is over 6. So these are a little bit more restrictive guidelines than the Diabetes Canada ones, which would be over 4. Now, if you've identified a person with hypoglycemia unawareness, they can maintain their license or reinstate their license if they have had at least 3 months since an episode of hypoglycemia, which is generally enough time to reinstate awareness. And that their physician says awareness is regained and their glycemic control is stable. And they need to actually test immediately again before driving and every 1 hour. And they don't start or continue driving until their blood glucose is over 6. So very similar to patients with severe hypoglycemia episodes. So being even more careful. Now, commercial drivers, there's always more restrictions for commercial drivers. So if they've had an episode of severe hypoglycemia, they can have their license back if they have no more severe lows while they're awake or asleep in the past 6 months. And they need to actually provide their healthcare practitioner at least 4 readings a day for 30 days. And they're quite restrictive on the amount of hypoglycemia that they can have, so less than 5% readings, less than 4. That's something we're used to looking for anyways on reports from CGMs or FGMs. So always take a look at that. And they must test immediately while driving, before driving, and every hour. And then the same thing with not being able to continue or start driving unless their blood glucose is over 6. And if the person has persistent hypoglycemia unawareness as a commercial driver, unfortunately, they're not eligible for the initiation of a license or reinstating their license. So it's a good impetus to get people's hypoglycemia unawareness treated. Now, this is just a table sort of listing the recommendations that I went through. So easily print outable if you'd like to do that. And now the New Brunswick Department of Public Safety makes some recommendations around diabetes and commercial driving as well. Specifically the supplies that are needed in the car. So obviously self-monitoring equipment, rapid-acting carbohydrates, and your insulin or whatever treatment that you're on. Again, testing blood glucose within 1 hour of driving and every 4 hours during driving. Stop if blood glucose is less than 6 until they start to rise after food, so not specifically being prescriptive about how long to wait. Maximum of 12 hours a day driving as a commercial driver. I don't know if you're able to separate that into like split shifts. I have patients who drive a little bit longer than that as split shifts. So anyways, maximum 12 hours a day is recommended and maximum 6 hours between meals. So people should be assured to get their meal breaks. And their work schedule should be approved by their physician as compatible with their insulin regimen. So I've had a lot of people do shift work, overnight driving, and things like that too. And as soon as they switch to day shifts for one reason or another, I've recommended it for some people. They really do have improvement in their glycemic control and less hypoglycemia. So it may be something to discuss with the patient and do a trial with their work. So finishing a little bit early, but there are a lot of recommendations about this. So to just be aware of the evidence behind driving recommendations, that people's cognitive resources decrease at a blood glucose less than 3.8, and it takes quite a while to recover from hypoglycemia, so they really shouldn't start driving for at least 40 minutes. And to know that, yes, we are preventing accidents and maintaining patient and public safety by talking to people about driving. So it is really quite important. And to know the reporting requirements in your province, whether it's discretionary or mandatory. And here in New Brunswick, it's mandatory. And to let people know that it is mandatory and tell them exactly when you're going to report them. So there's no surprises. People don't like surprises. I don't like surprises. And to understand differences in recommendations for private versus commercial drivers. So, in general, the management of driving in commercial drivers is more conservative and less permissive for any episodes of severe hypoglycemia unawareness, and they are generally recommended to be a little bit higher before they drive. And to be very aware and ask about severe hypoglycemia and hypoglycemia unawareness, especially in folks who drive commercially. And this is my truck of candy. You will know if you work with me that I love candy. So what I've encouraged folks to do, and what I do a lot myself, is just ask, do you drive? And then it leads into a conversation of, okay, great. Do you check your blood glucose before driving? Okay, why not? And then to talk about the reporting requirements in the province. And if you remember anything, remember this grumpy cat that says, I'm not going anywhere until you check your blood glucose. And then you can all read this very hilarious joke before our question and discussion period.
Thank you very much, Dr. Mackenzie. That was a great review of all the guidelines that are out there. I know one of our challenges is that there are so many guidelines and trying to figure out, which ones are most applicable to which patient, because as you've pointed out, the province varies from other sources. Specific to diabetes educators, certainly one of our questions is always, what's our role in making sure that the physician's aware of hypo incidents? Because as I understand it, the mandatory reporting requirement applies to the physician. Is that correct?
Yeah, it does. So most definitely to establish the person in your clinic, especially if you're in a multidisciplinary team who's going to ask about driving and who's going to talk about the reporting requirements for driving. So that's probably the biggest thing to do, is actually just have someone ask about it, and have someone ask about it regularly, at least once a year. The same as we screen for complications, like, okay, did you have your eye test this year? Great. Do you drive?
Perfect. So it's just, I think, one of those habits, right, that we just have to get in. And it is, like you say, making it part of that routine, that with the foot check, with whatever comes that discussion about driving. So awesome. Any other questions or comments for Dr. Mackenzie?
I see so many in the chat. Oh gosh. I'll try and mediate my own questions here.
I think that a lot of the questions kind of came from some of the differences between guidelines, that kind of thing. Yeah.
Right. Yep. Let me see. Is it possible to have access to my slides? Yes, and I did put in a 3-page chart at the end that actually summarizes and compares guidelines, each of the 4 resources that I was talking about. So as long as you follow one of them, it should be reasonable. And as long as you're asking regularly.
And we have somebody making a confession that they have a tendency to not ask about it maybe as often as they should. And I think it is kind of one of those things that, when you're new to diabetes, there's a whole lot of things to learn, and that perhaps this is kind of one of the things you learn a little further down the road. So ha! Yeah. One of the other questions has to do with the commercial driver regulations going into the US, and I know there was a change in those recently with regards to insulin, right? that's something you know about right off?
Yeah. I don't off the top of my head going into the US actually. Um, I don't know specifically. Hmm. Yeah,
No problem. It is
sorry
hard
about that.
information to locate. I've actually called Department of Public Safety and stuff a couple of times to try and get a copy of what it says, and I've done some Googling. So if anybody happens to know where we can find that resource in writing, if you would stick that in the chat box, that would be great. There's another question here that says, do we have a responsibility as an educator if a patient was to go to court and it was found that their crash was diabetes related?
So you may possibly be asked to give evidence in court. I wouldn't volunteer evidence on anything unless you're asked. And to always offer the patient ongoing follow-up care as well, to say that I am still working with this patient, or what have you, about mitigating their severe hypoglycemia or what have you, and these are the steps that we're going through. So they get actually the benefit of the court knowing that they're still working with you. But yeah, unless you're asked, I probably wouldn't volunteer evidence. And I would talk to the patient about, like, hey, if you're being legally pursued for this, they might ask me for evidence. I would
And
like you
I've
to
actually
give it
had
just to keep
a
them in the
commercial
loop.
driver say, they didn't want FGM or CGM because they felt it was like a rat box, so to speak, that there was more of a better record of any hypoglycemia they might have had. So it was, that difficult conversation to say, well, we can work through the hypoglycemia, but we really need to, focus on your health and making sure that you can stay driving as long as you want. So, yeah. Ah,
Yeah, like we can't treat what we don't know is happening. So it's really hard, and it really does actually discourage people from reporting to their physicians whether or not they actually have hypoglycemia. But as long as you have a pretty open relationship with the patient to start with, hopefully they'll be able to be
perfect.
honest
And I
with
see
you.
Gina has posted a link to the diabetes driving guidelines. So it's in the chat box. We appreciate that, Gina. Thanks very much. And if there's no
Yay, bless
further
you.
questions or comments, we can. Oh, and Shelly has some other information as well that we can send out. I know she has a personal connection to the industry, so it's something she knows about. We can perhaps just use the next few minutes to go back and visit the sponsor booths, that kind of thing, chat at your tables amongst yourself, and we'll start with the next speaker at 1:45. So thank you very much, Dr. McKenzie, for joining us today.
All right, thank you. And like, feel free to chat me with any questions, and presentations will be available. Thanks.